This presentation is a summary of how to start drug treatment for ADHD. I will address some clinical questions such as which stimulant to choose, clinical pearls of short and long-acting formulations, and when to use atomoxetine. So let's begin with some guidance on how to choose medications. The first-line treatment for ADHD are stimulants. This includes methylphenidate and amphetamine. Are there any differences in efficacy? Actually, they have similar efficacy. Treatment with stimulants in children, adolescents, and adults produces a response in 65 to 75% of patients. In contrast, only 4 to 30% of patients show response to placebo. So, stimulants are the most effective drug treatment for ADHD, with effect sizes of about 1. Here are two examples of clinical situations we might say in practice. We have two patients. Patient A did not respond to methylphenidate, but showed response to amphetamine. Patient B did not respond to amphetamine and showed response to methylphenidate. This is only to point out that some patients might respond to one stimulant and not another. In conclusion, if the first stimulant was not effective, there is a 20 to 40% chance that the second stimulant will be effective. We should keep this in mind and try a different stimulant if the first one fails. There are other questions that are helpful in choosing medication. Is there a family history of response to stimulants? A stimulant with non-response can be a good first choice. Now, regarding formulations, can the child swallow pills? If not, we can choose formulations that can be crushed or opened. If we decide to use dexmethylphenidate, the D enantiomer of methylphenidate, we need to remember that dexmethylphenidate dose is 50% lower than methylphenidate. Now, regarding formulation choice, a fair question is, when is it appropriate to use short-acting formulations? Short-acting formulations can be useful as additional treatment to long-acting drugs. A short-acting formulation can be given in the afternoon when a long-acting medication starts to wear off for activities that require focus and concentration, such as homework or other after-school activities. Short-acting formulations can be given upon awakening to reduce symptoms during the morning routine. What about long-acting formulations? They have clear advantages. A longer effective response decreases the need to receive medications within the school setting. This decreases stigma associated with medication use. The problem is that if side effects emerge, they may extend throughout the day. So, which drug and formulation should we prescribe first? The long-acting preparations of methylphenidate or amphetamine are considered first-line treatment for ADHD. As we previously saw, they have similar efficacy and side effects profile. So let's see now some practical considerations when using long-acting formulations. Wax matrix formulations such as Ritalin SR, Metadate SR, and Methylene ER must be swallowed whole to retain long-acting properties. This means that they shouldn't be crushed or chewed. On the other hand, beaded formulations are helpful for children who have difficulty swallowing pills. This is because the capsules may be opened and sprinkled into soft foods. As a reminder, some examples of beaded formulations include: for methylphenidate, Metadate CD and Ritalin LA; for dexmethylphenidate, Focalin XR; for amphetamine, Dexedrine Spansules and Adderall XR. What are the differences between long-acting preparations that influence treatment planning? The first is duration of action. The second is cost. The third is the child's ability to swallow pills. And the fourth is the risk of abuse. Now a brief summary on starting treatment. First-line options for ADHD in children, adolescents, and adults are stimulants. This includes methylphenidate and amphetamines. Long-acting formulations are considered first-line treatment. If the first stimulant doesn't work, we should switch to a different stimulant, as this may work in 20 to 40% of cases. It is also wise to start on a weekend day. This allows parents to watch for adverse effects with the first dose. What about atomoxetine? When should we use it? Atomoxetine should be considered after methylphenidate and amphetamine have been ineffective or poorly tolerated. Atomoxetine is a suitable option for patients with a history of illicit substance use or for patients who have family members with a history of illicit substance use. Atomoxetine has advantages and disadvantages. As we just saw, atomoxetine has lower potential for abuse and is not a controlled substance. Disadvantages: initial therapeutic effects are gradual. It can take 2 to 6 weeks to see a peak in efficacy. There is also a bolded warning for increased potential for suicidal ideation.